So it's my honor to be here to discuss calcium in different settings, ACS, bifurcation, and the CTO lesions. First of all, the ICS. 10 years ago, there was a paper publication for the focus on the capital lesion of AC in patients with ACS. So there is three major capital lesion characteristics. One is a rupture, and another is a CTO OCT erosion, and the OCT calcification. Especially for the calcification is not popular in daily practice, but it's popular for some special patient populations, just like chronic kidney disease and the older patients. So there is another paper published that showed that for ACS patients, the coronary intervention for the calcified lesion in ACS has a poor outcome compared with a non-calcified lesion in patients with ACS. The result of the same paper showed that if the patient's capital lesion with severe or moderate calcification lesions, the post-procedure flow with no zero. It means very high compared with other patients. So I'm sorry. So we also can see here, if we focus on the long-term outcome at 1 year follow-up, there is a higher MACE with patients for the patients with severe or moderate calcification compared with other patients. So there is another very interesting outcome focus on the time to event curves at 1 year's follow-up for target lesion calcification. We can see especially for the stent thrombosis was very high with non-calcification lesions. So another paper published in 2016 adapted DES trials, we also can find that if the patients have the patients with ACS for the capital lesion with severe calcification lesion, not only for the TVF and the MACE and myocardial infarction was very higher compared with others. And now in 2022, there is another paper published that for the ACS patients, the capital lesion has 5 characteristics. One is a plaque rupture, which means the presence of fibrous cape was discontinued with a cavity formation. Another is OCT definite erosion or OCT improbable erosion with intact or discontinued of the cap. The third is the calcification with the discontinued of the cap with thrombosis formation at the surface of the vessel, and another finally is a scar. So we show from there is 3 characteristics of the calcification in patients with ACS. One is look at here, superficial calcific sheaths, and B shows the calcification. C, we also can call it the loginal calcification without any thrombosis formation. So the question is there any difference between these 3 calcified lesions with patients in patients with ACS? We also find from this paper published in 2022, we also can see if the patient's capital lesion with calcification, the outcome is worse compared with other superficial calcification or calcified protrusion, which means loginal calcification, which means if the patient's capital lesion with thrombosis formation, the outcome was worse. But how to deal with this problem? The modification of various subtypes of calcium defined by imaging So in 2023, we also can see here is a recommendation for the different KSM in patients with ACS, especially for carpet lesion. If the eccentric KSM with alcohol less than 180, which means OCT CBI score was lower than 4, which means we can use only NC balloon, cutting balloon, scaling balloon to treat it. If the eccentric calcium score, just like OCT CBI score, was higher over 4, which means we use modification or debugging technique, just use a rota or bits or IVR. So if we find the loginal classification or classified login, so we should use some debugging or modification trial tell us to prepare the lesion first before we stent it. So we show you a case. This is our case 1 year ago. The patients with ACS, and when we find the angel, we also find the mild calcification lesion located at the distal part of the RCA, where even we use aerial and epicranial view here. So even though we find that the LAD was total occluded, but LAD was too small, we don't need to open it. So we try to treat the distal RCA first. We check with the OCT. OCT finding was very easy to find the carpet lesion with severe calcified lesion. Look at here. Look at here. Here is the login. Yes, we also can find the micro thrombosis formation here. We check the distance from the tip of the calcification to the opposite medial distance. The distance was about 1 millimeter. So how to treat this calcification? From the angel, we cannot find the severe calcification, but from OCT, we find the calcified here. So we want to use a rota with a 2O balloon, which is the largest balloon in China. We also use a 2O balloon. So after 2O balloon rotation, we check the OCT again. We also find that, hey, okay, the debugging here, we also can find the distance from the tip of the calcification to the opposite medium distance was larger compared with pre-PCI procedure. So after that, after we put another 4O stent with 4-5 NC balloon postulation, and we check the OCT again. We also can find the distance, and the stent expansion was very well. So based on the MLD MX criteria, the stent expansion was very good. So summary for the calcium in ACS, the more severity of the calcium of carpet lesion, the more worsen prognosis of patients with ACS. If the angel showed that the carpet lesion was only mild calcification, the presence of calcified lodule should be vigilant. Although the overall incidence of calcified in ACS patients is not higher, but the incidence of special groups such as the elderly and the patients with renal insufficiency is relatively higher. So how about the calcium in bifurcation? In 2021, there is a paper published focused on the calcification with bifurcation. If the lesion was only bifurcation and or only with calcification, but both of them MACE was only not very high, but combined with both bifurcation lesion with calcification was only 5% in all patients from over 20,000 patients registry trial. Nevertheless, the combined presence of both lesion prepare was associated with a strong and independent risk of adverse cardiac events over 1 year follow-up. This retrospective study published in 2021, a single center study evaluated the outcomes of orbits and rotational atherectomy treatment for severe calcified coronary bifurcation lesions as compared with non-bifurcation lesions. The result demonstrated that the atherectomy treatment in patients with severe calcified coronary bifurcation lesion is feasible, resulting in similar lower 30 days MACE compared with patients with non-bifurcation lesions. So in about 10 years ago, from Dr. Xiaoliang Chen's trial design, which named the definition trial, from 1,500 patients from January 2004 and 2006, confining factors for composite MACE were selected by logistic registry analysis. The rate of MACE treated by each confounding factors combined for several confounding factors were calculated. The definition of complex and simple bifurcation lesions was then established according to the predicted value of confounding factors. The major and minor factors, including the moderate to severe classification. If the one major factors plus the two minor factors, which means moderate to severe classification, or multiple lesions, or bifurcation angle less than 45 or over 70, or mean main vessel reference diameter less than 2.5 millimeter, or thrombus containing lesions, or main vessel length over 25, which means complex bifurcation lesion. In 2020, Dr. Xiaoliang Chen published another definition 2 trial on European Heart Journal, and confirmed that if the bifurcation lesion was complex with treated with 2-stent technique, the 1 year follow-up can get a very good outcome. So in 2023, Dr. Xiaoliang Chen has the expert review to show that the definition criteria for left main bifurcation lesion from clinical need to formula, which means if the complex bifurcation lesion, we should treat the lesion with 2-stent technique. So in another paper published in 2022, EBC also defined the complex bifurcation lesion from the angio or intravascular imaging or coronary CT. We also can find a calcified lesion was also the very risk factors for the complexity of the bifurcation. So summary for calcium in bifurcation lesion: PCI for severe calcified lesion is a challenge due to the inherent risk related to the inadequate stent expansion and the side branch compression. Therefore, adequate lesion preparation with dedicated tools is often required. Modified balloons are effective in lesion preparation, but their use is undermined by lower crossability. Atherectomy has been available for 30 years, only as ROTA, or more recently it has evolved as OPITS, allowing a higher success rate with an increased complications rate as straight valve. IVL are now promising devices that obtain calcified plaque fragment with a sonic pulse or locally delivered, but the clinical translation for such benefit is still being determined. So next we say something about calcium in CTO. Physiological of calcium in CTO. Early in the development of a CTO, the plaque is always soft or fibrous tissue. There is low calcification. As occlusion ages, the composition typically becomes denser with a fibrous tissue and calcified deposit. Such longer duration CTOs are more heavily calcified than those of short duration. But following CABG, there is accelerated progression of atherectomy in the native coronary arteries, possibly mechanism for the including blood status and lower shear stress due to the compactive flow from the graft. The development of a new CTO in an artery post-CABG is common, occurring in 43% of patients within the first post-operative years. CTOs in post-CABG are often higher complexity characterized by more extensive severe calcification. And the incidence of economic of
Sorry,
calcium.
yeah.
I'm
Yeah. 1 minute.
okay. I just go quickly. So the procedure challenging calcium CTO PCI. Calcium is common located at the proximal cap, resulting in difficult with wire. So common wire escalation, de-escalation based on the wire position. Another very interesting tools with IVL or pot tactic is used for the CTO wire crossing. A procedure challenging is cast for CTO lesion, rota or laser after wire crossing, or IVL after balloon crossing is very, very useful. Summary for calcium in CTO. Coronary calcium is prevalent in CTO, particularly in those of longer duration and post-CABG. The presence of calcium predicts a lower procedure success rate and a higher risk of complications of CTO PCI. Adjunctive imaging, including pre-procedure CT and intracoronary imaging. Especially guide wires and microcatheter, as well as penetration, subintimal and entry and lumen and re-entry technique are required to cross calcified CTO lesions, and use of both atherectomy devices, balloon-based